distorted anatomy. What would be your advice for people to to go about these kind of patients? I will start from him. Can we have the other microphone, please?
This is one of the key aspects of a consultation, balancing what patients want with what patients need. And it can be a very interesting dialogue, it can be a quite time-consuming dialogue. The easiest thing in the world, the quickest thing, is for us as consultants to give patients what they're asking for, even if they're asking for something that is aesthetically and functionally inappropriate. And it's a strategy which allows many patients to be treated in a day, albeit with interesting or questionable results. I personally feel that our responsibility as experts in our field is to educate patients as to why we don't recommend a particular course of action. I do find it takes longer during the consultation, but generally I find that patients are receptive to this approach. That if we explain to them why it's not appropriate to be putting more filler in their lips, why they need restoration of support to the lips, rather than augmenting the lips to ridiculous proportions, that they do understand that. I think patients are a lot more intelligent than we give them credit for. I talk to my patients about signs of fillers, about bony resorption, about fat compartments. Now granted, I'm in Washington, D.C., I'm on the east coast of America, where there's a horror of having huge lips. Patients don't have breast implants, they're not flamboyant the way you're used to seeing for American patients who are from California or from Florida. It's a lot harder with my patients from those regions, but I try.
Any other insights from the panel about going against your gut feeling, trying to address the patient's desires, and they are informed patients. They have been treated before. They come to you, say, oh, I had them nice, now it's 9 months since the last treatment, I would like them bigger, but to you, they don't look, like deflated or in need of any treatment.
Okay. I do the following. I always put myself in the shoes of the patient, and I say this to the patient. Firstly, it takes me much more time to turn down a patient than to inject, in 10 minutes, make money, and that's it. So I tell them, listen, if you were my sister, if she has the age of my mother, my wife, my daughter, if it was for my own face, I wouldn't do it. So I mean, and if they insist, I wouldn't do it, definitely. And so I had to, in our city, in Casablanca, we are known as, people come and they have 50% chance to be turned down. I refuse more than 53-55% of the patients that I see every year. So whenever, for example, somebody has been injected elsewhere, and I feel if she was my sister, could I help her? If the answer is no, I wouldn't touch her.
Okay, another technical question, maybe to Suad. Looking at all these different techniques of injection, if we are to think injection technically,
Okay.
If we are to think of a simple approach, I like very much that how you say it, you have to look after the frame, and you showed that very nice picture how addressing the mammalian border as well as the perioral aesthetic improved the aesthetics already. In relation to the volume of the lip, are you in agreement with median tubercle of the upper lip to lateral tubercles of the lower lip? 3 injection points is adequate to start, with somebody who needs a little bit more, or you have much more injection points, and how do you go about starting lips? Because most of our students, find it quite risky or scary to start injecting their first lips. So the borders are easy,
Yeah.
but you know the volume, always worry about all these proportions, you know, duck versus humans, etc. So how would you start? What's your advice for a starter in the lip injection for volume, you know, as a simple technique?
Okay. I like always to make it simple. So it's a good question for me. I often start with the lip border. In patients, in Asian patients, okay, because this border become not well defined. So this is the first step. This is often the first step, and then we can inject the tubercles, okay, and we can either inject from red lips or from white lips. From white lips, I used this technique a few months ago, and I like it very much. Can I show this on? We cannot have this
No, on
there.
peut pas la voir,
No.
c'est un peu-
Okay, so with a needle, I use usually needles. I come from white lip and I introduce the needle and I go where the median tubercle for the upper lip, and with the same needle, I go from white lip to red lip and I inject like this. If the whole lips are very, very, very thin, so I can use 2 points laterally, another point in the median tubercle, and two injections laterally. I can achieve with this quite nice results. For the lower lip, I can use 3 points, 3 and 3 points from white lip to red lip, and I inject here. From white lip to red lip, 3 points on the right side and 3 points for the other side. And like this, I inject few amount of milliliters of product, and my patients are happy with this. They want natural results, and it's okay for me.
Thank you very much. Just one
Then
moment.
I use the needle that the manufacturer gave.
Okay, the question was which needle you use. May I ask Hema, what do you think in relation to the product choice? I know that when you are experienced injector, you try to be more versatile and you can be more kind of, outside the orthodox. You can use whatever you are comfortable with according to the characteristics of the products. But many of the manufacturers put aside one of their range to the lips. How much forgiving is the product in relation of how it goes, how it flow inside the lip and correct itself with the available anatomy of the orbicularis ori if there is some mistakes in injecting, and how much, what is the trade-off between injecting techniques and the usage of the products which are advertised for the lips?
Well, the interesting thing is that if we take that specific product from each product line which is intended for the lips, very often I find that it's a great universal product. It's the one product that you can inject all over. I'm not going to name brands, but I think you all understand what I'm saying. It's the one product you can put in the perioral region, the temples, the forehead, everywhere. Now why? Because these products tend to be softer, a little bit more cohesive, and they are engineered to swell less. And all those characteristics are very useful throughout the whole phase. One of our major evolutions has been towards thinking of tissue expansion rather than tissue projection. When we used to use hard lumps of filler, we were thinking more of projecting aesthetic points in the face. Now, as we understand more about fat compartments, we understand it's more important to look at aesthetic units. and to be expanding those than if we are projecting to be projecting a whole unit. And this type of product is engineered to do that for the lips as a whole aesthetic unit, and it often is very useful for the other units of the face.
And then how forgiving is that in relation of the technique? So if you use the product labeled for the lips, which is the most versatile, and you go for 3 injection points according to the tubercles, for example, would it all be okay within 2-3 days if in the clinic didn't look, wow?
Okay.
Will it correct itself, or you have to leave the patient leaving the clinic with this, wow, it will not sort itself?
As a general rule, what Dr. Saad said is absolutely correct.